Good afternoon, everyone. So I will be talking about tissue glues in corneal perforation. So corneal perforations, they are ocular emergencies which as present they are being managed by various conservative measures like BCL, tissue glues, sutures, as well as permanent measures like DALC and PK. These sutures have their obvious disadvantage in the form of long surgical and healing time, risk of infection, scarring, and astigmatism. Now, tissue adhesives, they cover most of these disadvantages, but whatever tissue adhesives we are using till date, they have disadvantages of their own. So we are yet to find the ideal tissue adhesive, which has to be cost effective, transparent, easy to apply, biodegradable, biocompatible, should set rapidly, provide healing enhancement, in situ cross-linking, and should also have post-operative comfort. Most importantly, it should be a strong adhesive to the naturally moist ocular surface, because most of the tissue adhesives, they require a dry ocular surface, which is difficult to achieve. Tissue adhesives are broadly divided into biological and non-biological, which we all know. But the most commonly and the oldest tissue adhesive which has been used off-label is cyanoacrylate glue. It is ideal for perforations which are less than 3 mm in diameter, concave in profile, and away from the limbus. It is having additional advantage of being bacteriostatic and disrupting the stromal melting. So that's quite an important point. So this is how the healing happens with the cyanoacrylate glue post-operatively. Now, the newer derived longer alkyl side chain derivatives of cyanoacrylate glue, they have additional advantage of being more biocompatible, that is less toxic, but their tensile strength and bacteriostatic activity is less as compared to the shorter chain derivatives. Now, as far as the technique of application is concerned, for smaller perforations, the routine we can do, just we have to ensure that the field is dry and a small amount is applied through a 27 gauge needle. That really helps in putting a small amount, and initially apply a thin layer. If required, you can repeat. For larger perforations, technique 2 is recommended, that is the drape technique, gluing a disc of sterile plastic drape, which is going to help you with creating a barrier between the anterior chamber and the glue. Then there are certain variants of this technique. One is the 10-0 nylon suture mesh is being created between the over the perforation, and over that the glue is applied. But again, that can be little surgically tedious in a perforated eye. Double drape technique is also being advised for larger perforations to create that barrier. Then there is this scleral patch graft augmented. Instead of drape, here you are using the scleral patch for the creating that barrier, and along with that the cyanoacrylate glue is applied. This technique helps in non-infectious corneal perforations where the melting in the periphery is continuing, the disease process continues. So in those cases, it is really helpful, and it can work even for larger perforations like 3.5 to 4.5 millimeters. So this is how this scleral patch augmented technique works over these peripheral sterile perforations. Complications are mainly related to its toxicity, causing stromal, endothelial, and lenticular toxicity. IOP can also rise because of inflammation of the trabecular meshwork. An infection mainly related to the prolonged use of BCL, which is very much avoidable. Then there is another synthetic adhesive, which is the PEG, which is polyethylene glycol based, which is safe, well tolerated, elastic, biodegradable. Disadvantage is it is not appropriate to function as a stromal filler. It requires a completely dry surface. For a post surface, it is doing fine, but when there is loss of tissue, so there that poor mechanical property is going to come in way. Then comes the biological option, again commonly used, that is the fibrin glue. So it is completely biodegradable with very less toxicity. So for defects up to 2 mm, it is as effective as CAG. But the disadvantage, it degrades more quickly, it does not have antibacterial properties, and has the risk of transmission of the viral disease. Now, this infection part can be controlled by various measures, but the safest would be to prepare the fibrin glue from the patient's own blood, so that factor can be very much controlled by this particular option. Technique of application, it can be applied simultaneously. For that, you need to have a duplicate syringe. or that completely depends upon the surgeon preference. And then there can be a sequential application where you apply thrombin first, followed by fibrin. So that can be identified as a thicker and thinner component. You have to explain it to your technician. So this is just a comparison which we have already discussed of the two commonly used glues. So as we can see, all the glues have the advantage but disadvantages as well. So we have to pick and choose. But the clinical need for a fast curing strong tissue adhesive is still, remains unmet. And various polymers, they have been tried, of which this gelatin is a promising biomaterial considering its availability, cost effectiveness, water solubility, and presence of cell binding sites and metalloproteinases. So this basically, it works in situ within 2 minutes using the UV light and a riboflavin sodium persulfate system. It has shown to fill the corneal wounds and restore the corneal curvature and providing a very smooth surface. And its burst pressure is comparable to CAG, transmittance, water content, and storage modulus similar to the normal human cornea. So this is looking quite promising. So these are the properties of Gelma bioadhesive, and this is how it works. So I will be just winding up. These are the other options other than glues that you can, you have in-house, and you can always use that, flaps and AMG if it is available, and Tarannum patch graft, that also is quite helpful. But when you are not, cannot, resort to any of these measures, you have to go for keratoplasty procedures, which can again depend upon the size, location, and cause of the perforation. So take home message from my side: management of a corneal perforation depends upon the size, shape, location, and very importantly, the cause of the lesion. Smaller lesions can be, managed with tissue adhesives, Tarannum patch graft, AMT, but larger perforations need urgent keratoplasty. Number of new adhesives currently under research, but long-term trials are definitely required still to establish their efficacy. Gelma bioadhesive seems to be a promising option. Thank you very much. Thank you for your patient hearing.
Nice presentation, ma'am. Have you used? Thank you.